Good afternoon, everybody. So, I am really thankful to the organizers for giving me this topic to discuss on clinical cardiology, understanding S3 and S4. And I am sure that they have kept this topic for junior doctors, not the senior doctors. Most of the persons present over here, they are seniors. But junior doctors are really lacking because they are busy in presenting their cases. So this would be just recapitulation of our earlier studies in our studentship. So please excuse me if it is really boring you anyway. So it is really meant for the junior doctors. So heart sounds, we all know that each cardiac cycle gives birth to 4 sounds. Each cardiac cycle is producing 4 sounds rather. First heart sound and second heart sound, they are very healthy. We are very much pleasant to hear that 2 sounds. But whenever S3 and S4, the last 2 sounds make their appearance, the patient's relative as well as sometimes doctors get panicky. That means we are expecting some pathology in the heart. So we are really not wanting in our lifetime that 3rd and 4th sound of each cardiac cycle. But it will definitely come in our life sometime, in many of our life definitely. So in phonocardiogram is really a very important instrument to find out all these sounds, whether it is audible to us or not. And 3rd and 4th sound is our real concern today, whether it is really panicky or not. So in phonocardiogram, what we see, S1, S2 is being flanked by S4 and S3. As S4 is just coming before S1, that's why it is sometimes called pre-systolic sound or S4 sound. And as it is being produced by the atrial vigorous contraction, that's why it is sometimes also called that it is atrial gallop. And the S3 sound comes after S2, that is in the diastolic period, and early third of the diastole, that's why it is sometimes called protodiastolic gallop. So atrial gallop, protodiastolic gallop. Now, if we hear S3 in young persons, in athletes, during pregnancy, in children, not to be panicky, because it is physiological. Because they are really having compliant heart. They really relaxing their heart, dilating their heart within physiological limit in the early part of the diastole, that is the early rapid filling phase, and that give rise to development of S3. And rest, if you hear randomly whether S3 is present there or not, out of 100 S3s, 40% of S3 will definitely be associated with some pathology of the heart. So we have to be careful whether S3 is there or not, and if it is there, whether it is physiological or not. Now, generation, why do S3 occurs? S3 occurs, there are 2 things. One is oscillations of blood back and forth between the walls of the ventricles and is initiated by inrushing blood from atria. And whenever the blood is rushing from left atrium to left ventricle due to gradient, they really does produce tensing of chordae tendineae and thereby giving rise to that soft sound. And occurs just after S2, I have already showed that thing. It's a low frequency sound. Its frequency is almost to the tune of 40 cycles per second. And that follows A2, that is the second heart sound aortic component, by 120 to 200 milliseconds. Now, where it is best heard, it is, you all know, it is best heard, could be heard in the supine posture. But if you are thinking that your clinical scenario, S3 is quite likely, if you are not being able to auscultate in supine posture, please try to make the patient on left lateral position and put your stethoscope at apex. After palpation, you try to find out where lies the apex and keep the bell of the stethoscope there at apex. In left ventricular S3, you put bell of the stethoscope at the apex, and in right ventricular S3, you put your bell of the stethoscope in the left fourth intercostal space parasternally. And if you want to make it more audible, more distinct, you ask the patient to hold breath in expiration and hand grip exercise. This will definitely make indistinct S3 more distinct. It is also known as ventricular gallop. How the patient's position is being shown over here. This is the left lateral position. She is palpating, first palpating where lies the apex. Then she is putting her bell of the stethoscope very lightly. Now, in phonocardiogram, all the time you are in each and cardiac cycle, you are getting this sort of S3 marked red, but this is normal. You are not being audible. But I have said that if there is any be a bit pathological due to some other pathological conditions that I will come to later, it will definitely be little bit more, cycles will definitely get increased, its duration get increased, and it is audible over here. So S3 sound is often sign of systolic heart failure, because why we do get panicky, because whenever S3 is present, especially in a patients who are above 40 years of age, we definitely think that patient is definitely having little bit of ejection fraction reduced. It could be within normal limit, because ejection fraction ranges from 55 to 75%, but on serial echocardiography, if it is really getting reduced from 75 to 65 or 60, something like that, and you can hear S3 in that patient, you can be jolly well, take that conclusion, come to that conclusion that patient within a short time may develop heart failure. So you can give some protective molecules to that patient from the very beginning when patient has already started overt heart failure. This is the S3. Gallop, that typical cadence. The third are sound, lap da da, lap da da, lap da da. Now, I have already said why it is because the right panel, this heart is dilated and muscles are thinned out. Whenever in the early diastolic phase, rapid filling is occurring, and that gives rise to development of S3. Now, what could be the most closely mimicking sound in our cardiac auscultation that may mimic or that may confuse whether it is S3 or something else? So you have to go for DD if you are thinking S3, whether you are missing that suspected S3 that could be closely related to split S2 or opening snap. Split S2, A1, a pulmonary component and aortic component. If they are really very distinctly split, the second component of that heart sound may mimic S3. Even when we are all aware of opening snap, when opening snap is occurring in a patient who is having mitral stenosis, that may again get confused S3. So how to differentiate these two things? Split, second heart sound, and opening snap is a high pitch sound, and S3 is a low pitch sound. And S3 is always localized. That's why I showed you what would be the typical site for patient while you are auscultating. That would be left lateral position. But S2 or OS, you will be able to hear it in any areas, cardiac auscultatory areas of a patient. And most important part, you try to push the stethoscope bell or diaphragm of the stethoscope, because nowadays stethoscope is available only with one diaphragm. There is no bell and diaphragm. If you push it firmly, it will act like diaphragm. If you keep it lightly, it will act as bell. So if you push it firmly, that suspected S3 or split S2 or OS, whatever it may be, it will be more distinct. So if it is becoming more distinct by pushing the stethoscope on the apex of the heart. It is either split S2 or OS. But if it decreases in its intensity or it disappears totally, it is S3. So this way, the site, whether it is audible in all cardiac areas or with firm pressure through stethoscope, it is disappearing or getting more distinct. That could be important points in differentiating S3 from OS or split S2. So I have already discussed a little bit what could be the causes of S3. One is physiological, I have already said, children, adolescent, young adult, pregnancy, etc. But there are some S3, apart from this physiological, they are distinctly hard, but that may not be that pathological, that may not be related to organic disorders of the heart. That is your anemia, pregnancy, and thyrotoxicosis. Because of the hyperdynamic circulations in these three conditions, we may get distinct S3, but no organic heart disease. Now, some organic heart disease like rheumatic valvular heart disease, like mitral regurgitation, tricuspid regurgitation, or aortic regurgitation, they are very commonly associated with S3 if we really meticulously hear all these patients. But one thing is to be kept in mind. Whenever S3 is there, we definitely think in the line of patient is showing impending heart failure. It is not in the regurgitation valvular heart disease. In MR, AR, and TR, they only indicate that the regurgitation is severe. And you all know that whenever we are coming across multiple valvular heart disease in the form of MS associated with MR or isolated MR showing S3, that means whenever they are having MS MR, MR is definitely predominant. So banking upon only auscultatory finding in MS MR combined heart disease, combined valvular heart disease, if there is S3, it got to be significant MR. It is dominant MR compared to MS. And whenever we are getting in AR, MR, or TR, that means the regurgitation is significant. So hemodynamically significant regurgitation, that doesn't mean that heart is failing. But congenital heart disease, sometimes congenital heart disease, that gives rise to development of S3. What are those? When there is left to right shunt, as in ASD or VSD or PDA. If there is VSD and PDA, there will be left-sided S3, and if there is ASD, there would be right-sided ASD. There would be ASD. And if there is VSD and PDA, there would be left-sided S3. And in ASD, right-sided S3. So what is the significance of getting S3 in these congenital heart disease? That means the LR shunt is significant. So in your clinical diagnosis of all these three congenital heart diseases, you are definitely on bedside trying to evaluate whether it is significant or insignificant. Because significant LR shunt, you have to go for operative measures at your earliest possible time. You have to advise at least. So congenital heart disease with S3, I have told the significance of it. Now poor prognosis. Whenever you are getting S3, when the relatives, you have to educate relatives that heart is really failing. Whatever I have discussed right this moment up to the causes of these, up to congenital valvular regurgitation, hyperdynamic circulation and physiology, you don't have to be that much worried. But when it is associated with ischemic heart disease, when it is associated with dilated cardiomyopathy, you have to be very cautious. You have to treat from the very beginning in an aggressive way so that the heart failure will not aggravate to a great extent. Now coming to the fourth heart shunt, the second part of my topic. It is almost similar to that of third heart sound because it is a low pitch sound, because it comes in the diastole, but in the later third of the diastolic period. That's why it is called the pre-systolic sound. And as it is being contributed by the atrial contraction, so it is called atrial gallop. So whenever patient will have arrhythmia in the form of atrial fibrillation, it is not possible to get S4, you all know. So atria not contracting AF, that means S4 absent, and it occurs just before the first sound, almost 110 milliseconds prior to S1. The lambda, the lambda, the lambda. The first sound is your fourth Earth sound. So generations of the fourth Earth sound is almost like third Earth sound is not well explained, but it is being said that atrial fibrillae, in atrial contraction, whenever blood is being rushed into the left ventricle, that the time when it is decelerating after hitting the ventricle, that fourth heart sound is being generated. And the causes of fourth heart sound on the left side is hypertension, then comes your aortic stenosis, then hypertrophic cardiomyopathy and ischemic heart disease. Here I like to tell you one thing. I have told you so many S3s where you shouldn't get panicky. But whenever you will find out S4 it is there, it is always pathological. So clinical significance of S4 is much more important compared to S3. So and the right ventricular S4 you will be found here. Left ventricular S4 is systemic hypertension, here it is pulmonary hypertension and pulmonary valvular stenosis, and there left it was aortic stenosis. One thing is to be kept in mind that it is a textbook teaching and we have been taught that way. Whenever you are getting S4 in a patient of aortic stenosis and A wave is prominent in jugular venous, you all the time think of severe significant aortic stenosis. But now it has been little.
Professor Karmakar,
yes.
This is a pre-lunch session. We are hungry.
2 minutes, sir.
Hello.
One. And S4, I was important sign of diastolic heart failure. It is important sign of diastolic heart failure. So that is in S4, that is the non-compliant cardiac muscles. So it is due to non-compliant cardiac muscles, so patient contraction is okay, so its ejection fraction is all the time preserved. That's why it is being said it's heart failure but with preserved ejection fraction. So here the S4 presystolic, this is also presystolic, but whenever it is getting loud and higher in its pitch, it is being audible. So S3 ventricular gallop, S4 is atrial gallop. How to differentiate all these things? How it signifies clinically? Occurs in early diastole, I have already said. That's why it is called protodiastolic gallop. And occurs in late diastole. That's why it is called atrial gallop. Occurs during passive left ventricular filling. Occurs during active LV filling due to contractions of the atria. May be normal at times, but almost always abnormal. Requires a very compliant left ventricle for production of S3. Requires a non-compliant LV. That is the first and foremost thing for generations of S4. Can be a sign of systolic congestions, that is heart failure with reduced ejection fraction. Can be a sign of diastolic congestive heart failure, that is heart failure with preserved ejection fraction. So my last slide, I definitely acknowledge the help of Dr. Sandeep Ghosh as well as Dr. Atanu Chandra for getting me all these videos and everything. And references are textbook of Barnward, Haast and Topol. Thank you for your patient hearing.